recommend them some alpha S1 facet blocks. They do get excellent relief from their buttock pain. Sometimes even the SI joint can cause buttock pain. So then that can be taken care of by giving a small injection. These patients have dramatic relief if you give injection in SI joint or alpha S1. So
Okay.
my experience with this pyriformis syndrome hasn't been like, I don't know. I haven't treated it as pyriformis syndrome. I've always treated it as either a alpha S1 facet arthritis or a SI joint pain. And they have done very well.
Okay. And sir, one thing more. अभी हम लोग देखते हैं काफी young people लेमिनेक्टोमी के लिए जाते हैं because of their pain and all. So sir, you have discussed about this ASD. So doing laminectomy in a young individual can lead to adjacent segmental degeneration in the later age.
No. You got that concept a bit wrong here.
No, you said कि laminectomy done wrongly or a part is removed more like that.
that can cause instability and back pain. So that instability, the surgeon caused instability. Usually, all well-trained orthopedic and spine surgeons won't remove so much lamina so as to cause instability. It is not very common. What I'm talking about, the adjacent segment degeneration, it's a condition which occurs post-fixation. So for the adjacent segment to degenerate, this operated segment should not move. That movement has been taken over by the adjacent segment, and then it degenerates at a faster rate. So if you have done laminectomy, the movement will still occur because there is no fixation in that segment there. So laminectomy will not cause adjacent segment degeneration. That if a patient with, let's say, L4, L5 laminectomy has developed L3, 4, 5 symptoms or degeneration, that's an independent event. It's not related to the laminectomy. But if the L4-5 fixation patient has developed adjacent segment degeneration, it could be an independent event, but it could be due to fixation as well. We can label it as an adjacent segment degeneration, but it's difficult to comment whether it was due to fixation or it was a independently occurring adjacent segment degeneration. So it's a gray zone. But laminectomy definitely won't cause adjacent segment degeneration due to the laminectomy.
Okay. Thank you, sir.
So, what is your take on lumbar canal stenosis? And how do you think there, because most of physios, they observe that there is a very narrowed approach as far as lumbar canal stenosis is concerned, and these patients might get complications like foot drop, and then we have to follow it up with stimulations and other things. So what is your recommendation on the rehabilitation part?
Yeah, so let's say a patient, most of these patients will have a foot drop to begin with. So let's say it's a L3-4 very tight stenosis. So usually what has been my experience is that a chronic condition like lumbar canal stenosis will usually present as more of symptoms and very less signs. So they will have all the symptoms of claudicant, back pain, leg pain, tingling, numbness, but they will not have any weakness. They will not have any deficit. Usually deficit occurs in patients who have got a superimposed disc herniation on a lumbar canal stenosis or a primary disc herniation to begin with. So these patients, when there is a sudden pressure on the nerve, then it develops these foot drops. The chronic patients usually they don't develop foot drops unless it's very late. Unless it's very late and the patient has been avoiding surgery, they might come to you with foot drop or even cauda equina syndrome. And let's say I have operated on such a patient, then the recovery cannot be predicted. You might give nerve stimulation and all those things, but still the recovery is absolutely not predicted. You should never promise the patient. Even preoperatively, we counsel them that it's all your luck. We will decompress the nerve, but whether it will conduct again or not is not something I can promise. Absolutely no guarantee that he will recover from his deficit. So always we recommend them to get surgery done if the deficit has started developing. Then there is a good chance that they will recover. If it's a complete foot drop, they may not recover after surgery.
Okay. Sir, we have another question. Sometimes after laminectomy at L5S1, patient complains of numbness after 3 months or numbness presents in surgery and it doesn't completely go away. What can be the reason for that and what we as physiotherapists can do?
Yeah, so for symptoms of numbness or weakness, you should not promise anything in first place. These symptoms, no matter what you do, they may not recover. The patient with a foot drop may have a foot drop throughout his life, no matter how much efforts you put in. So don't promise anything. Do give your nerve stimulation things for a period of maybe 2 to 3 months. If they don't recover, there is no point giving beyond that time, because if they haven't recovered within 2 or 3 months, they are not going to recover. So there is no point. Regarding numbness, whenever my patient complains of numbness, I always tell them that the benefit of surgery is maximum for the pain. Their numbness might persist for a variable duration of time. Sometimes it might be their lifelong. So tingling numbness are a bit weird symptoms. They may or may not settle, though most of my patients do well, their tingling numbness does settle, but you don't promise. You don't promise about these are some kinds of conduction deficits. So all I can do is remove the pressure on the nerves. If the nerve can conduct well or not, nobody can promise. So tingling numbness, don't promise. They might last for 6 months, 1 year, or they might persist for lifelong. Your surgeon can't do anything about it.
Okay.
The pain will definitely go.
Okay. Okay, sir. Now we have the next question. So somebody is asking, what is a failed back surgery syndrome and how as a physiotherapist we can manage it?
Yeah, so failed back surgery is not something a physio can manage very well, because it's something the surgeon has done not right. So lumbar spine has always got a good amount of lordosis. So many of the surgeons don't understand this. There are implants available in the market where, if you might have seen a lot of my surgery pictures which I have shown, there is an interbody spacer there. So this spacer, if you can see my hand here, it is supposed to be lordotic. Like the front part of it should be taller than the back part of it. So that will maintain the lordosis of the lumbar spine. So there are surgeons who don't use a lordotic cage. They might use a parallel cage. And in these patients, they lose the lordosis of the spine. So this is a kind of sagittal imbalance. These patients might have adjacent segment degeneration, which is faster than other patients in whom the lordosis has been maintained, and they might develop a flat back. So these patients do tend to have long-term pain, and many of their pain does go away if you correct the sagittal profile of these patients. So they might require surgery again. But of course, if everything has been done well and still the patient has back pain, then they will have to do just some strengthening exercises. Then probably the surgeon will not be able to help you, because if the implants are right, if the structure of the spine is right, the sagittal coronal balance is right, and still the pain is there and we are not. See, for a surgeon to intervene, it's not a simple thing. You have to put the patient under anesthesia. There is a lot of money involved. The patient has to pay from his pocket, or his insurance company has to pay, and they have to undergo a trauma of surgery which has got a lot of risk factors. Revision surgeries are difficult, they are complicated, the results are never as good as the primary surgery. No matter how well a surgeon does this, the results will never be as good as the primary surgery. They will always have some or the other complaint. So we have to think very carefully before we recommend a revision surgery for any patient. So even if it's a failed back surgery, you have to understand the exact cause, why it is a failed back, what has gone wrong, what has not been done properly. If I can understand that, if the surgeon can understand that, only then he will recommend the surgery.
Okay.
Otherwise, the more number of times you do surgery, the worse the patient will be after every surgery. You have to do it right. So the first time is the best time always.
Okay. So next question is, in case of a degenerative lumbar canal stenosis at L4 and L5, how effective is a root block for radiating pain?
So for a lumbar canal stenosis, I usually don't recommend root block, because I think in the first session itself I had told this, because it's a very narrow canal. So if you try to inject anything into the canal, there is no space there. If I put in a needle, it's going to puncture the dura. There is no epidural space. Epidural space is space between the dura and the bone or the ligament, like the space around the nerve. So that gets stenosed, it gets very tight. and that's the condition called as lumbar canal stenosis. So in these conditions, you don't give anything into the canal. However, if this patient complains of only one-sided leg pain, like a radicular pain, we might give a root block to these patients to sort of see if the pain can be alleviated. But like I said, if the condition is reversible, only then the root block will have a permanent effect. Otherwise, once the effect of the root block goes, the patient will again have his symptoms of leg pain. If the disc is still there, if the compression is still there, he will again have pain.
Okay. Sir, if a patient with lumbar canal stenosis have started with symptoms like numbness, tingling, is it advisable for them to undergo surgery, or till the time till wait, or should we wait till a stage till the deficit sets in, or it should be, or should it be managed conservatively? So what are your suggestions on that?
Yeah, so for a lumbar canal stenosis or for a disc herniation, like in a knee replacement, if you guys know, the predominant reason for operating is pain, or if there is any motor deficit.
Deficit. Okay.
If there is only tingling, numbness, and no deficit, and there is not much pain, I won't advise surgery, because the patient may not get so much of a relief. The tingling, numbness might remain even after surgery. So, how does a patient perceive the benefits of surgery? It depends on what is the difference between the pre-op symptoms and the post-op symptoms. That's how we will say how successful the surgery was. So let's say the difference is not big. So let's say his pre-op pain score was 5. No matter how good I do the surgery, his post-op pain score is 3. Then the patient won't say, ठीक है, surgery हुआ, इतना कुछ आराम नहीं है, अभी भी दर्द है. But let's say a patient has a pain level of 10. I do the surgery and then it comes to 3. The patient will be extremely happy that it's a successful surgery. He has done a great job. He's a great doctor, etc., etc. So it
Okay.
all depends on the difference. So if your initial level is bad, then the patient will be more happy.
Okay. So we must wait for the patient to be, totally humiliated, and then we should also
No.
suggest
It
surgery.
all it's a counseling thing.
Yeah.
Prerak, if a patient is significantly disabled, if he has
Mm.
got pain, we do recommend,
Okay.
but I don't enforce surgery on the patient. I
Okay.
tell him the pros and cons involved. So
Okay.
if he doesn't, there are patients who have foot drop and still they don't want to undergo surgery. It's fine. It's
Okay.
their life. It's their spine. I mean, they like to live with it. It's okay.
Sir, fewer patients complain of burning sensation in mild to moderate intensity along their lower limbs with in and off tingling. What can the reason for that be?
So yeah, this is a very good question. Whoever has asked it.
So Dr.
So
Akshita Joglikar has asked this question.
yeah, so let me clarify it for all of you that don't do or recommend a surgery for burning. The burning symptoms are not related to spine compression. They will never get relieved by surgery. So I had a patient who had got severe instability of the spine, severe pain in the lower limbs due to L4-5, alpha S1 instability and severe lumbar canal stenosis, very unstable spine. I did a complete job, did a decompression, fixation. All her pain went away, but pre-operatively she had burning. She has completed almost 6 or 7 years after surgery now. All her spine-related symptoms other than burning have gone. And I had counseled her pre-operatively that everything will go, but your burning will not go. So they are perfectly happy. They are perfectly happy with the entire surgery because they have been informed. They have taken an informed decision that the burning won't go after surgery. Rest, your tingling, numbness might go, your pain will definitely go. And if you give the results which you have promised, the patients are happy.
Okay. So what can be the reason for burning? And that too in
It
and
is,
off.
I think you should have a session from a neurologist
Okay.
because this is something which I don't know. It is some conduction abnormality. And
Okay.
even the neurologist I know of, they are not able to treat this burning. So
Okay.
you can grill them in your next webinar. But why do patients have burning? So
Okay.
they will keep giving pregabalin, gabapentin, and
Okay.
nortriptyline, those kind of drugs. Patients have persistent burning. So
Okay, sir.
as a physiotherapist, definitely you shouldn't promise that with your physiotherapy the burning will go. It will not go. No matter how much they do, whatever they do, they take all kinds of medicines. A lot of diabetics do have this burning sensation.
Hmm.
So